if you look at page 29, you'll see these terms demonstrated on the drawings there. So we already talked about the glabella. The intercanthus is the inner portion of the eye where the eyelids come together. If you have an intercanthus, then naturally, Allie, could you let Brooklyn in? Then naturally you're going to have an outer canthus. The nasion is where the frontal bones and the nasal bones meet up, and that would be what a lot of people call the bridge of the nose, right? The infraorbital margin is just that, it's the bottom of the eye. The acanthion is where the nose and the upper lip come together. So that's going to be a point, the centering point that we're going to use once we get into facial bones. The gonion is kind of where the angle of mandible is, right back here, not to be confused with, again, the inion, which is this thing back here. But the gonion is that angle of the mandible, where it goes from vertical to more horizontal. The EAM we already talked about, the auricle point. Really, what we're going to call that is going to be the top of the ear attachment, is what we're going to refer to rather than the auricle point. All right, so that's all of that just in demonstration. You got the drawing in your book. So landmarks that you need to be aware of, and the things that we're going to use, the lines that we're going to use are for positioning. For right now, pretty much are going to be the orbital meatal line, the infraorbital meatal line, and not so much the glabello meatal line. But what that is a line that would extend from the outer canthus of the orbit, the orbital meatal line, outer canthus of the orbit, out to the EAM. Okay, so it will be a line that will go from here out to that way. That line is what we're going to refer to as the radiographic baseline. There's another line, the infraorbital meatal line would be what we refer to as the Reed's baseline. I don't think that's in your textbook. And because of the shape of a kid's head, the infraorbital meatal line is also the radiographic baseline for children. Okay, so if you find yourself, positioning skull work for a kid for whatever reason, probably won't. But if you do, then you just need to make that adjustment. Instead of using the OML, you're going to use the IOML appropriately. So the OML for skull work, for the most part, is going to be perpendicular or parallel to something, be it the central ray, be it the image receptor. It's going to be considered on each one of those. So radiographic baseline. So you've also got a line, interpupillary line. Interpupillary line would be the line that runs in between the two pupils. So where you're going to use that is when you position for a lateral skull, what you want is the interpupillary line to be vertical. So what you can do is take something, even if you just use your pen and you just lightly hold it like that, it should be vertical, right? If you're barely hanging on to it just tight enough that it stays between your fingers, it should be fairly vertical. So when you're positioning for a lateral skull, what you're going to have to do is you're going to have to get because most people aren't this flexible, you're going to have to get the patient to oblique their body a little bit. You're going to have to get them to you ever been to a professional photographer and they put your head in that weird position, Okay, you're going to have to do that to your patient to get them into a good lateral. So you're going to have to get them to oblique themselves a little bit, and you're going to have to get them to kind of contort their head a little bit. And what you're trying to do is get the infraorbital meatal line perpendicular to the front of the image receptor. That's the least important thing, but the most important thing is to get that interpupillary line vertical. Or if you got them upright, it will be perpendicular to the image receptor to be horizontal. Okay, so the acanthomeatal line, we're not going to use much here, but later in the semester we're going to use it quite a bit. The acanthomeatal line would be from the acanthion, that's again where the nose and the lip come together, out to the EAM. And then the mentomeatal line we've used before, again in C-spines, that's what we use for the fugues, if you recall. So we're going to use those two lines later in the semester. All right, so we don't really use the glabello-alveolar line or glabello-meatal line, but we do use the OML, OML, and AML extensively, and to a lesser degree, the mental midline as well. Okay? Skull morphology, we already talked about. General body position, is the patient going to be upright? Are they going to be prone? Are they going to be supine? Remembering again that we want to shoot PA if at all possible, but because of body build, sometimes you may have to take some steps. All right, so if you look on page 32 and 33, that's what this is describing. If you have a patient who is asthenic and you're trying to do a lateral, then you may have to build the patient's chest up in order to get the inner pupillary line perpendicular. If the patient's hypersthenic, you may have to build the head up a little bit in order to do the same thing. So on our AP views of the skull, what we want is the orbital-meatal line to be perpendicular to the image receptor. Now, I can tell you, this doesn't have to be body habitus. A lot of people, whenever they lay flat, they put their head back, they're not going to be able to tuck the chin down enough to put the back of their head on the table to get the orbital meatal line perpendicular to the image receptor. So you may have to build their head up a little bit in order to accomplish that. If you can't build their head up, what's your go-to move? Angle the central ray until it's parallel to the OML. Right. So build the head up if at all possible. If they're in a collar on a backboard, you might not be able to do that. So angle the X-ray tube to parallel the OML. All right, so lateral looks like that or that. Interpupillary line perpendicular. And we just talked about all of this. So radiation protection, we already talked about. Any kind of artifacts, remove them. Eyeglasses, removable teeth, removable eyes. You know, if a patient has a glass eye, you're going to know immediately. Hearing aids, jewelry, wigs and hair pieces, weaves have pins in them for miles. They have a ton of pins. Ponytail holders, prosthetic eyes, the hair clippies, all that stuff needs to come off of the patient if the patient will allow it. So our central projections are going to be lateral. So our lateral, it could be left lateral, it could be right lateral, it doesn't really matter. You prefer to put the side of injury closest to the image receptor so that you don't have loss of sharpness recorded details. So it could be left lateral, right lateral, doesn't really matter. Most of the time people are going to do left lateral. The only problem with putting the injured side closest to the image receptor is in a lot of cases the patient won't lay their head down flat to accomplish that, right? So consider that as well. All right, so sometimes your lateral is going to be cross-table lateral. Again, in a trauma situation, you're going to shoot cross-table lateral. We've got PA. Anything we can do PA, we can do AP. So we're going to do PA and AP, and our positioning is going to be identical on both of those. Then we're going to have a PA axial, which is a Caldwell method, and we're going to have an AP axial, which is a Town method. Again, anything we can do PA, we can do AP. So we can do an AP that is equivalent to a Caldwell method, and we can do a PA that is equivalent to a Towns method. Okay? The Towns method, the PA axial that looks like a Towns is going to be named something different, and that's going to be a Haas. Okay? So I'll show you how, or tell you how to recognize the difference between those whenever we get to it. But first, what I want to do is I want to do this. Just to illustrate what I was talking about earlier, if you look on page 34, what do you see? What projection is that?
The lateral.
It's lateral, right. So that's, you know, looking at the banner at the top, what does it say?
Skull.
Skull, okay. So flip over to page 55, and what does the banner at the top say? Orbit. What does the position look like?
It's the same.
It's lateral. So if you flip over to page 58, what does the banner at the top say? Facial buckles. What does the position look like? It's lateral. If you flip over to 68 was better at top safe. Nasal bones, what's the position there? Lateral, right. So flip over to page 85, was the position at the top safe. Or the position at the top, better at the top safe.
Temporal mandibular articulation.
TMJs, right, so was the body position there?
Lateral.
Lateral, same thing on page 86, also same thing on page 92 for sinuses. What do you suppose the difference is on each one of those?
This one's centering.
Central ray and collimation, central ray location, collimation. Positioning is identical on each one of those. That is, the interpupillary line's perpendicular, the infraorbital meatal line perpendicular to the front edge of the image receptor. Okay, so let's go back to page 37. So that's skull. Banner at the top says skull, right? So what line is perpendicular to the image receptor? OML, right. So that would be a PA, okay? So if you flip over to page 40, what line is perpendicular to the image receptor? OML. Right, so what do you think you're going to see on both of those? Same thing, same thing. All right, so only thing is one is AP and one is PA. Again, PA is going to be preferred, but sometimes you got to shoot AP. Now flip over to page, yeah, I don't want to do that one. I don't want to do that. I got my color coding a little bit confused here. Okay, if you flip over to page 66, what do you see? And you're holding your position on page 37 and you flip over to 66, what do you see? PA, right? So it's the same thing. The point I'm trying to make here is we're going to do the same thing over and over and over again for the rest of the semester, pretty much. We're going to add some views here and there, but for the most part, what we're going to talk about this semester, if you learn it this time, then you know the rest of the semester is going to be it's going to be easier. It's going to be a review. By the time we get to sinuses, the sinuses lecture is about 20 minutes because we covered it all. It just there's just not a whole lot to add to it. So with that in mind, we'll go to the lateral position or lateral projections, both position and projection. So the patient position, again, you're probably going to have to oblique the patient up a little bit. Most people can't lie flat on their stomach and turn their head into a good lateral position. So you got to oblique the patient a little bit, regardless of whether they're upright or laid on the table. So what you want to do is you want to put the patient's interpupillary line perpendicular to the image receptor. The OML being parallel to the transverse axis of the image receptor or perpendicular to the front of the image receptor is for uniformity, really. And that's going to be your positioning for each one of these laterals is that and that, is that and that, okay? So if the purpose for the uniformity is so that the radiologist, if you're reading a lot of skull x-rays, doesn't get one that looks like this, and the next one looks like this, and the next, it's just uniformity. Of the two, that's less important. That is very much important. That's going to determine whether or not the patient's rotated and whether or not you can see what you need to see, okay? Certainly do this, but absolutely do that, okay? So lateral projection, what we want to do is put the interpupillary line perpendicular, OML parallel to the transverse axis of the image receptor. And now what you're going to do is you're going to extend your radiation field about an inch, no more than an inch past the skin line, and you're going to put your central ray 2 inches directly above the EAM. Okay? So, on a skull, what we're looking for are those skull bones. Is this a skull bone?
No.
Okay. So, you're going to run into some differences of opinion on whether or not you need to include the mandible. Just go with who it is that you're working with, right? But by the textbook, you don't necessarily need to see the mandible on a lateral of the skull. Okay? So, if your doctor wants you to include the mandible, certainly include the mandible, but your textbook positioning is just the only thing that you're looking for is skull bones. So you want to get from top to the bottom of the skull, front to the back, the petrous pyramids on top of each other, sella turcica without any kind of rotation, meaning that the anterior clinoid processes are on top of each other, the posterior clinoid processes are on top of each other. The easiest thing to do is to look at the EAM and also look at the top of the mandible. If your mandibular rami, the upper portion of your mandible should be, your TMJ should be superimposed. If you've got, and I know my fingers are, like this because of the divergence of the light, but just look at the shadow and not my fingers. So they should be superimposed. So if you've got one that's anterior to the other, then what you've got is rotation, right? If you got one that's superior to the other, then what you've got is tilt of the head, okay? So you want clinoid processes superimposed, you want your TMJ superimposed, you want the orbital roofs superimposed. So all of those things are, the mandible's easy to see, orbital roofs, a little bit harder to see, petrous pyramids, perfectly superimposed, harder to see, the sella turcica without rotation, harder to see. All evaluation criteria, but the easiest thing for you to evaluate is that mandible, okay? Don't need to see the peak of the mandible, but you're going to see, from at least here up. So take a look at your TMJs to determine any kind of rotation or head tilt. All right, so positioning, mid-sagittal plane, mid-sagittal plane positioning and mid-coronal plane positioning. Make sure that you've got that worked out. Your mid-coronal plane on a lateral is going to be perpendicular, mid-sagittal plane is going to be parallel, right? So trauma positioning is going to be cross table. Everything still applies. Really, you're not going to worry at all about the OML and whether or not it's going to be parallel to the long axis of the image receptor. Mainly what you're going to be looking for is, did you get a good lateral? That's number one. And number two is there air fluid level in the sphenoid sinus? One other thing that you might consider is that because of the divergence of the central ray, what you might do is put the image receptor, if you're ever doing a trauma, put the image receptor down below the backboard, or if you can, build the patient's head up a little bit, because the divergence of the central ray will project the base of the skull off of the image receptor. But, that being said, if you don't see the base of the skull, you still have telltale indicator that the patient has basilar skull fracture. That would be fluid in the sphenoid sinus, right? All right, so all that's still the same. No difference really. So what we want to see is evidence of proper collimation. We want to see, the entire skull without any kind of rotation or tilt. All that stuff superimposed, like what I was talking about before. No overlap in cervical spine by mandible. That will be your extension of the skull, extension of the chin with the IOML parallel. So that's what it should look like. Top to bottom, front to back, and what we're going to look for is the mandibular rami being superimposed, which they look like are perfectly superimposed on this one. No rotation of the orbital roofs or the sphenoid sinus, or the sella turcica. That is the sphenoid sinus right there, right up under the cell. Good lateral skull. Okay. So things that you might want to look for on the patient themselves, look on the x-ray for fractures. Fracture lines kind of look a little like open sutures, but they're not on the suture line itself. So the suture is going to be kind of jagged looking, fractures are not. Sometimes skull fractures are depressed, so they're pushing in just a little bit. Patients sometimes will have raccoon eyes, especially if they ate the airbag and they got broken nose. In a lot of cases, both of their eyes will be black. So again, opacity is sphenoid sinus indicates a basilar skull fracture. If you do a skull and you've got, maybe this is non-trauma, you shoot a skull and it looks like the patient has a whole bunch of little bitty holes or areas of increased density on the image, that would indicate decreased density of the bone, tying this back to imaging. That will be an indication the patient has multiple myeloma, METs maybe, metastatic cancers. So, I said that most of your fractures don't follow the sutures, but this one almost looks like it does. A little fracture there, linear fracture here, depressed fracture on a CT there. This is on a baby, and if you ever see a skull fracture on a baby, somebody needs to see that image immediately. Babies' skulls, I'm not going to say they don't break, but babies' bones are much more flexible, right? And so a good indication, two good indications, patient had some sort of abuse, really three. Multiple fractures in different stages of healing. You may have already heard about that in patient care. That's one, but skull fractures and rib fractures are highly suspicious for child abuse because they flex so well. I'm not saying that they're, all the time, causes child abuse, but they are a telltale sign. All right, so just other stuff, this right here, this is bad. This is much more than just a tripod fracture, but this guy's in bad shape. But a tripod fracture will be a fracture where you get disarticulation. This is zygomatic bone, so you get disarticulation from the zygomatic arch, temporal bone, frontal bone, and the maxilla. But he's got much more going on there than that. So that's multiple myeloma. All right, so PA Caldwell, PA and Caldwell. So the positioning for PA and Caldwell are identical. And that is, we're going to shoot PA, so the patient's face is up against the image receptor. Orbital meatal line is going to be perpendicular to the image receptor, okay? In both of those cases, positioning is identical. So what you want to do is put on some gloves and use their ears. Most people are pretty symmetric, right? I mean, there are some people who, look like, it's an old movie, but anybody seen The Goonies? Okay, so there are some people like Sloth, right? They're just completely asymmetric. Lyle Lovett, anybody know who he is? No? He was a country and western singer a long, long time ago. Ugliest man ever walked by. I mean, it's just, Time magazine did a thing about beauty, and it was, they did this thing, and they said that symmetry is really about beauty. They're trying to make the point. They showed a picture of Denzel Washington. They said he is almost perfectly symmetric. And by every objective, Denzel Washington is a pretty man, right? And then they showed Lyle Lovett. And Lyle Lovett's smiling, and one side of his mouth is up here, and the other side is back here, and he's just homely. So what they did was they took one side, reversed it, and put them together to demonstrate symmetry equals beauty. And what they found in this picture was he was still ugly, right? So most people are symmetric. And the point to all this is that if you put on your gloves and you put your hands right behind the patient's ears and you put your fingers, ears are here, you put your fingers where they're touching the image receptor, you're gonna have the patient not rotated in most cases. orbital meatal line perpendicular to the image receptor, mid-sagittal plane perpendicular to the image receptor, mid-coronal plane parallel to the image receptor. Collimate to the skin line, PA and PA Caldwell. PA Caldwell in this case is axial, and what the Caldwell is going to call for is a 15-degree caudal angulation. Now what's going to happen in this is, okay, so the orbits are all the way up against the image receptor. Anytime you put an angle on the central ray, what's closest to the image receptor moves the least. Okay, anything away from the image receptor is going to move more. So on the PA, what you're going to see is on the image, and we'll take a look at it here in a minute, but you're going to see the orbits and you're going to see the petrous ridges in those orbits, and it's going to completely fill the orbits up. The eyes are going to look kind of like straight off of a pirate flag. They're going to be kind of oval. The book, I think, says almond shape. Okay? So when we do the Caldwell, we put that 15-degree angulation on the image, or on the central ray. What's going to happen is the orbits don't move, but the petrous ridges, which are out here, instead of being projected in the top of the orbit, they're going to move down to the lower third of the orbit. Now the orbit's going to look more round, and the petrous ridges are going to be lower in it. Okay? So PA, petrous ridges way up here. Caldwell, positioning is identical. 15-degree caudal angulation on the central ray. Petrous ridges are going to be down here. Okay? So, PA is generally used when frontal bone is of interest. You know, the Caldwell we're going to use over and over again as well. Has no angulation on PA. Sometimes some of the texts will refer to any kind of PA or AP that is not a Towns or a Haas, we'll get to here in a bit, as some degree of Caldwell. So they'll say, you know, 10-degree Caldwell, 15-degree Caldwell, 25-degree Caldwell. Really the only Caldwell has a 15-degree angulation on it. So don't confuse it on the registry. Caldwell, 15-degree angle. Any angle besides that, not a Caldwell. Okay? So on the test, if you have a question that says you got a PA with 15-degree angulation, that is a Caldwell, right? So a PA with a 25-degree cephalic angulation is what we refer to as a Haas. We'll get there here in a bit. PA, 15-degree caudal angulation, 15-degree and caudal, that's going to be your Caldwell. Caudal, Caldwell. PA, caudal, Caldwell. All right? So the central ray is going to exit at the nasion. You're going to look for all the same stuff that we looked for before, proper collimation, no tilt, no rotation. But now we're going to look for symmetry of the petrous ridges and where the petrous ridges are going to be. So this is your PA. So see how the orbit looks kind of almond shaped or kind of oval? And then don't mistake this for petrous ridges. Petrous ridges are going to go straight across this way. That is the lesser wing of the sphenoid bone is what you're looking at right there. So petrous ridges go straight across. Caldwell, on the other hand, now look how rounded the orbits look. Petrous ridges are down here in the lower third. Okay, so PA, fill the orbit. Caldwell, lower third. Okay? So we're going to use Caldwell too whenever we look at the sinuses. I'm going to use PA. So we can do the same thing AP as what we do PA, we just got to reverse it. So on the PA, you know, we shoot 15-degree caudal angulation. On the AP, what will we do? 15-degree cephalic angulation. Everything else is identical. Evaluation criteria is going to be identical. The only difference in a testable question is how could you see a difference between a PA or an AP? PA or AP Caldwell.
Orbits are magnified.
Orbits are magnified, right. So your orbits are further away from the image receptor. They're going to be magnified. Now, are you going to be able to tell that off of a single view? The answer is no. You're really not. You know, I mean, You don't know what size of orbit that patient has unless you have both a PA and an AP. But still, carry that all the way through the registry. Your orbits are going to be magnified on AP versus PA. What else are you going to have if you shoot AP? Higher lens dose, worse for the patient. Higher thyroid dose, worse for the patient. All right, so AP versus AP Caldwell. Again, Petras ridges fill the orbits for the AP, lower third of the orbits for the Caldwell. Okay, so again, this is not a Caldwell, but with a 20-degree angulation, then what happens is as we increase our angulation, our orbits get more rounded and it pushes the Petras ridges further down into the orbit. So it's all the way at the bottom of the orbit. If we increase to 25 degrees, we would push them into the maxillary sinuses completely out of the orbit. What we'll start to see there, though, is, see these dark areas right here? It's an inferior orbital fissure, okay? So if that happens to be what you want to see, then you might consider a 20-25 degree angulation. But most commonly what we're going to use is 15-degree Caldwell.
Will the Haas be on the test?
The Haas will be on the test, yeah. Okay, so now we've got a different AP axial. AP axial with a cephalic angulation, right, is just the reverse of the Caldwell. Cephalic angulation is Caldwell. Okay, now this is going to be AP axial as well. AP axial just means an AP projection with the angulation on central ray. So this is the Townes method though. So where we're going to position here is where the central ray will pass through the foramen magnum. Our central ray is going to be directed through the foramen magnum at an angle of 30 degrees Caldwell. 30 degrees caudad. All right. So again, cephalic angulation. What we've got is the Caldwell. Now we're going caudal angulation, 30 degrees. All right, 30 degrees caudal angulation, AP axial is going to give us the Townes method. And what we're going to see with the Townes is, I wish I brought a skull. The occipital bone, you saw it in the pictures. There's a squamous portion, and then it wraps around so that we've got the foramen magnum down here, and it forms a pretty decent portion of the floor of the skull, right? So in order to see this and be able to visualize that potential basilar skull fracture, what we would need to do is angle so that the central ray is more perpendicular to that. Okay, we can't really move the patient's head, especially if they're in a trauma, but we can angle the central ray until we can see that a lot better. And that's the purpose for the Townes, is to see the occipital bone. Okay, occipital bone, 30-degree caudal angulation to see the occipital bone. All right, so that's if the patient can tuck their chin enough to get the OML perpendicular to the image receptor. I said earlier that a lot of people can't do that, right? So the difference in angulation is, skull topography between the OML and the IOML is roughly 7 degrees. So let's say the patient's in a collar, you can't move their head, can't tuck their chin, but their IOML is perpendicular to the image receptor, then you would compensate for that 7 degrees by increasing your angulation by 7 degrees. So the questions on the test will give you either one of those, right? OML, IOML, 30 degrees. I'm tripping up over this. The OML, 30 degrees, IOML, 37 degrees. Okay? In both cases, caudal angulation, what you're looking for is the occipital bone, central ray passes through the foramen magnum. So those are the things you're going to be looking for. AP axial, foramen magnum, occipital bone, caudal angulation, all imply the Town method. Okay? So what you're not going to see on the Town is orbits. All right? So on your lab test, if you see an image that looks like this and you see the big hole right there, and you don't see anything that looks like holes over here, and you get this big V shape like that, then you're looking at one of two things. You're either looking at the Towns or you're looking at the reverse of the Towns, which is the Haas. Okay? So, Towns, we got orbital meatal line perpendicular, 30-degree caudal angulation, right? So if we reverse that, then what are we going to do? You would think so. Yeah, you would think so. But if we used a 30-degree cephalic angulation, the images are going to look identical to this, by the way. But if we used a 30-degree cephalic angulation, what would we call that? Well, if this is a Towns, this would be a reverse Towns, right? And nobody would know who Haas is. So what Haas is going to do is he's going to require a 25-degree cephalic angulation. Gives us this same thing, but it's a reverse of the Towns. I think that's even a question on the test as well, is the reverse of the Towns is the Haas. Exactly? No. Effectively? Yes. Okay? So no orbits. The V shape to the petrous ridges. You want to see the foramen magnum in the center. Clinoid, you can't really see it on that one. You can kind of, sort of see it here. Posterior clinoid processes should be in the foramen magnum. Okay, so let me scroll up back to the APs. Where's the foramen magnum? That's just nasal cavity, really. Can you see it? If you can see something I can't, right? So you increased your angulation to 30 degrees caudad, and what do you see? Foramen magnum. What if you increased your angulation even more? What do you think you'd see? You didn't see it at all. You see it some. You see it more. You see it more. Right. So there's a couple of different angulations to see, to see a more complete image of the foramen magnum. I think you can increase your angulation to as much as 50 degrees. Your machine probably won't shoot that. You get to a certain degree of angulation and your machine thinks that you're trying to shoot tabletop, it probably won't shoot that. You'd have to set a technique in order to make that happen. But if you want to see more of the foramen magnum, you just increase angulation more. Positioning is the same. Orbital meatal line perpendicular to the image receptor if they can get it. If they can't get it, OML, increase your angulation, by that's 7 degrees. All right. So this again is the difference between the two. The Caldwell, again, the AP Caldwell, you're going to be angling cephalic. You're going to see the orbits on the Towns. You're going to see that V shape, and you're going to see the foramen magnum. Okay. So what to look for on the test? Caldwell 15-degree angle, Towns 30 to 37. Cephalic angulation for Caldwell, Towns caudal angulation. Caldwell is going to be what we refer to as general survey view. With the Towns specifically, we're looking for the occipital bone. With Caldwell, maybe the frontal bone. That might be more of a PA projection or AP projection. With Towns, we're looking for facial skull fractures. The Caldwell might mention ethmoid air cells, but in the Towns, not going to really reference any kind of sinuses. And they will mention the petrous ridges, but no mention the orbits. With the Caldwell, the petrous ridges are going to be within the orbits. With the towns, the clinoid processes are going to be mentioned in the foramen magnum, and with Caldwell, there is no mention of the clinoid processes. Okay. So the Haas, again, is a reverse of the reverse of the towns. The only difference, again, is that 25 degrees cephalic angulation to the OML. Notice that there's not a, IOML reference here. If you're shooting these PA, then you should be able to get that OML perpendicular to the image receptor. All right, so central ray enters 1.5 inches below the inion. Evidence of collimation, no rotation, fundamentally no different than the Towns in appearance. Towns versus Haas, really can't see anything. If you were to open your collimation, and the lab test may have one that includes mandible, both of these take up a lot of image receptor if you include the entire mandible. So with, again, the Caldwell and PA, what you've got is a nice oval shape, right? And with these two, it looks like something off of an alien movie. The skull looks like it's this long, just because of the, angulation of the central ray and the distortion. All right, so another one that we're going to see over and over again is what we refer to as a Schuler method. Schuler method is a, anytime we have a name attached, that's a method. But it's an SMV projection, that's submental vertical projection, meaning that the central ray comes from under the chin and goes out the vertex of the skull. So what we want to do is we want to extend the patient's chin far enough that the IOML is parallel to the image receptor. And this is going to take a lot. All right. So in order to get your patients into that position, what you're going to have to do is build the patient up. If the patient can sit in a chair, then it becomes a whole lot easier. You can have the patient slouch back in the chair and extend their chin. The IOML needs to be parallel to the image receptor. So the chin has to go all the way back until that is vertical, right? So you have a patient slouched down in a chair. Highly recommend you do not use a rollaway stool for this, okay? Use a chair, or at least a stool that doesn't roll. Vertex of the skull on the image receptor, IOML, parallel to the image receptor. Okay, so what if you have to do it on a tabletop and you can't build the patient up enough to hang their chin, their head off of whatever you build them up on? If you can't get the IOML parallel to the image receptor, what are you going to do? Angle your tube perpendicular to the IOML, right? So in a lot of cases, you're not going to be able to do this. You're not going to be able to get the patient's chin back that far. So in a lot of cases, what you're going to have to do is angle your central ray. Just put your central ray perpendicular to the IOML. What we want to do in doing that is to put the petrous ridges posterior to the mandibular ramus, or really the TMJs. So I'll point those out on the image here in a second. Oh, central ray passes a point 3/4 inch anterior to the EAM. Open your central ray until you get the base of the skull, which they did not do here. So there's the mandible. Those are your petrous ridges right there. The upper incisors are going to extend out past the front of the skull. What we're going to see this on then is sinuses. We're going to see it for the sphenoid sinus. We're going to see it done tabletop for the zygomatic arches, for cheekbones and facial bones. So we're going to see this one over and over again as well. Okay, so the ones we're going to do over and over, lateral, pretty much every one on every test. AP and PA on a lot of them, AP and PA Caldwell. Towns, we're going to see over and over again. Haas, it's an option, but we just don't see it a whole lot. For some reason, Towns is really the go-to, even though it's AP. And the Schulers, we're going to see, again, over and over again. Okay. Also with Schuler's, what we're gonna see are other views or other methods also named Schuler's. Okay? Any questions?